Now we're going to talk about a topic that doesn't upset anyone in this room. It's about opioids. I have been an expert in pain management. It's probably my area of expertise I've had most of my career. I also routinely and of necessity talk about chronic pain. I've worked in a chronic pain clinic for 10 years. I give lectures about addiction all the time. And in fact, I've just finished writing a chapter, an essay for Missouri Medicine's Journal about addiction issues in emergency medicine. The problem is we are in conflict with ourselves. We get very emotional about this issue, and understandably so. Why? Lots of people die. It's not that more people are abusing opioids than used to abuse cocaine or LSD or whatever in the past. It's just this happens to be a drug and a category that kills you. If you took LSD, sometimes you walked off a building because you thought you could fly, but that was rare. Usually you just drooled in a puddle. Opioids usually are not lethal. The problem is that people don't understand opioids. They don't understand a bunch of things about them. Doctors, users, everybody. They don't understand what they're being mixed with, fentanyl and carfentanil, and they don't understand how dangerous that is. We don't know how to prescribe opioids. We don't know how to assess risk for opioids or seem unwilling to assess properly. So we're going to try and get through all these topics in the next 30 minutes. It might not get done in 30 minutes, but I'm happy at any point during the conference to answer questions about this, because I'm sure each and every one of the people in this room, myself included, has multiple emotional stories. People swearing at you, people getting angry at you, people dying, and it's become a very complex issue when it shouldn't be. So why has this gotten to where it is? Well, one, people became afraid of street drugs because they were mixed with anything and you could die. No one knew what you were getting. So it became easy to take a pill that had a stamp on it that was given by a pharma company. You knew what you were getting, you knew the dose you were getting, and it couldn't be contaminated. Since 75% of adolescents, their first opioids came from their parents' prescription bottles, we, as professionals, had failed to instruct parents on how to protect them from their children. It became a fad about 10, 15 years ago to have salad parties. You know what salad parties are? It's when you bring your parents' medications, you pour them in a bowl, you mix them up with everyone else's parents' medications, and you take a handful and you see what happens. How many of you saw kids who did that? Right. As that became popular, well, they realized there's lots of other goodies in the pharmaceutical cabinet at home. And so 75% of adolescents' first exposure to opioids for recreational use came from their parents. Because we never taught the parents how to protect the medications. The number one source of prescription opioids for 2 years in a row, about a decade ago in Toronto, was houses for sale. Because people would go into the houses for sale, go into the bathroom, take the medications out of the bathroom, and take the opioids with them. And don't kid yourself, wherever you're living, that's still happening today. Because we never explained to people how to protect them. So there was this innocent approach that grew. The other problem was we became opioid happy in North America. If you take a look at what the WHO recommends for milligrams of morphine equivalent per capita per country, there are horribly bad countries in terms of pain management. For example, if you look at Taiwan, they prescribe 0.2 milligrams of morphine per capita per year. Why is that happening to such a little degree? Because of the opioid wars brought on by the British in the 1800s and the paranoia around opioids. The United States, however, for a decade, prescribed 3 times more per capita of opioids than the WHO recommended dose. If you take a look at the response of surveys for pain management satisfaction in Taiwan, which gets no opioids, and the United States was prescribes 3 times more than WHO recommendations, they're exactly the same levels of satisfaction for pain management. Which tells me that neither country has a clue how to take care of pain. That's what it tells me. So we thought we weren't giving enough pain medications. Then we became really zealous and gave way too many opioids because we didn't understand. If you go to a chronic pain clinic and talk to patients and ask them what made them get a breakthrough and get their pain under control, not a single patient talks about their medications. They all talk about the team support, the rehab, the coping skills, how they learn to manage their pain, how they learn to do things, et cetera, et cetera. And no one says, you know, and I took those pills for 9 months and it just made the difference for me. When I worked in pain clinics, it was straightforward. We told patients it'll take us 4 months to get your pain where it needs to be. You will never be pain-free. And by 9 months, we expect you to be off the medications because we expect your pain to be under control with other methods. They're a bridge. In acute pain, they're a bridge. When I went to New Hampshire and gave a grand rounds for the medical society there, they had helicopter surgeons because New Hampshire is a rural state. So surgeons would come in, they'd operate, and they'd leave. So what did they do when they left? Well, because they knew their patients would have some pain post-op, they would prescribe opioids in an almost unlimited quantity, 40 to 60 pills of something, morphine, Percocet, whatever, and they would have no verification as to how many pills were being used, how many were being diverted, nothing. There was no quality assurance whatsoever. Thousands of pills every day were being prescribed in New Hampshire with no one monitoring their use. That's ignorance on our part. So, between July 2016 and September 2017, 143,000 visits in 45 states were caused by suspected opioid-involved overdoses. That's a lot of overdoses. Again, it's because we don't understand. If you know a user who's taking a bunch of drugs, and they say, I want to stop, and they've been taking, let's just throw a number out there, 100 milligrams of oxycodone a day. And if you or anyone in this room took 100 milligrams of oxycodone, what would happen to you? To become constipated? You'd stop breathing. So let's ask a quick question survey of the people in this room. So this guy's taking 100 milligrams a day of oxycodone. He decides, I'm going to go cold turkey and I'm going to stop. Okay, and just like in train spotting, by day 2, day 3, he's got diarrhea, he's puking, he's diaphoretic, he feels like crap. How many days does he have to be in withdrawal before his threshold for that opioid falls back to as if he'd never taken one in his life? 4 days. If that person takes 100 milligrams of oxycodone on day 4 or 5 of withdrawal, he will die because his threshold for opioid sensitivity is back to normal. And not a single user knows that. And not a single person in this room knew that. And so how do you tell them, the person who comes in and says, well, I'm trying to get off opioids, man. I'm good with that, but you have to remember, man, if you get to day 4, you got to start really low again if you're going to use. How many of you told a patient that? That's why they get into trouble. Because their threshold disappears within 5 days in everybody. So, we always think of these people as being assholes. Because they're in here asking for drugs. You know what? They aren't. In this room, there's roughly 100 people. That means 13 of you have the genetic trait to be an addict. It's not because you're not nice. It's not because you have a weird personality. It's not because you're dependent. Genetically, that's just the way it is. If I was to take everyone in this room, how many went to university? Come on, how many of you went to university? How many of you went to a kegger? Come on. How many of you got drunk at least once in college? Right. How many of you became alcoholics? Almost none. 13% did. because they had the genetic trait. There is someone in this room, and I don't know who it is, who probably got hammered every weekend, every year of college. And they're just fine, because they didn't have the genetic trait. If you take the genetic trait and you then give it stimulation, it's sort of like someone who has a genetic trait for diabetes, juvenile diabetes. They get exposed to something, usually a virus, that triggers the gene and sets them up to destroy their pancreas and become diabetic. People with this genetic trait are exposed to certain nutrigenic and epigenetic factors. They eat a lot of fatty foods. They eat a lot of dopamine-stimulating foods, junk foods. They get abused. There's depression. There's bullying. There's these social factors that trigger the genetic trait. It's been shown clearly that that has to happen for the genetic risk factor to be triggered, which is why the opioid risk tool asks, have your parents got a history of psychiatric problems? Were you abused as a child? Is someone in your family got alcoholism? It doesn't ask about who's taking opioids, because that's irrelevant. It looks at the factors that trigger the genetic trait. Once that genetic trait has been triggered, I've had people tell me after 2 pills they were in trouble. I have a friend of mine who's a physician. He said, I had a spinal hernia. I had spinal surgery, and they gave me some Percocets. He says, I took the second pill, and I threw the rest away because I felt so good. I knew I had to start taking more, and I was going to get into trouble really fast. That was his second ever opioid pill. Just like I learned with my first ever dose of fentanyl that I don't have that trait. I was on a stepladder, fell off the stepladder because it broke my radial styloid. They said, Jim, we're going to give you some fentanyl because we have to cast and reduce your wrist. I remember 2 things 5 minutes after I got the fentanyl. 1, I had no pain. And 2, I never wanted this drug again. I felt horrible. I felt so dysphoric. I hated every second that drug was in my body. When I had surgery later, my wife would start crying because I was in so much pain because I refused to take the prescribed opioids because I felt so bad taking them. I hated the way I felt. It's not the same for everybody. So, here's how we have to approach this. How did we get over our paranoia of AIDS? How many of you were around when the AIDS epidemic started? How many of you remember professionals they worked with who refused to see those patients? Right? People would walk away, they'd be abandoned, they were socially isolated until we did what? Universal precautions. We assume everybody's at risk for bloodborne pathogens, we wear gloves, we do things the right way, and suddenly we started taking care of people properly. That's how you have to look at opioid risk. Doug Gourlay, and there's some references in the chapter, talks about universal precautions. You assume since 13% of the population has a risk, that everybody's at risk. So you ask the appropriate questions. You use a screening tool. And I don't want to hear the arguments that have been thrown around because those are just excuses to not do the job right. I've heard it takes too long to do. I've heard, well, they haven't been validated in the emergency department, as if your subjective impression of the person in front of you has been validated somehow. Your gut feeling is wrong more than 50% of the time. We are terrible at identifying someone who's at risk for opioid misuse, opioid use disorder. And it's been shown in multiple studies that if you use an opioid risk screening tool, of whichever one you want to choose, it's way better than subjective impression. I've been told by peers, well, I can't use it, it takes too long. How does it take too long? I give a piece of paper to the patient and they fill it out. It's too personal. It asks too personal questions. They won't want to fill it out. You know what I find? I just tell everybody, I do this for all my patients if I'm going to prescribe opioids. You're no different than the next person. I do it for everybody. It's universal. This is how I practice. I've got nothing against you, but you've heard about the opioid epidemic. So you can understand why I want to make sure I don't do harm to my patients. So I ask this of everybody. They all fill it out. 100%. It takes them about a minute. Some of them refuse to fill it out, which already tells me the answer I want to know. Some of them are dishonest and lie. I understand that. But it's not like they're not going to lie to me anyway if I use my own subjective impression. Do you use drugs? No, not me. And you actually believe that? So the excuses for not using the risk tool are just that. They're excuses for you not to do your job. We're concerned about the epidemic, so let's do this properly. If the person scores medium or high risk, and you're not sure, then do a urine test. Because let me tell you something, those urine screening tests aren't really good. But if it's tests positive for cocaine, they've taken cocaine. And if they're taking cocaine and they're asking for opioids, it's because they're selling their opioids to get cocaine. And if it tests positive for heroin, it really is positive for heroin. Those are the two things you can take money to the bank and say they're taking that. So that helps you further. You can limit the number of pills you prescribe, but remember what I told you, it only takes a few to get the person going. And if it tests high risk, you sit down and say, we're going to take care of your pain, but we're not going to be using opioids. You do it with everybody. It becomes a pattern. And you know what? After, like anything else, after you develop a pattern, it doesn't take very long for it doesn't slow down your practice. It really doesn't. Yep. It's part of the medical record in my hospital. And if you want, the opioid risk tool is actually on MedCalc. So it's not like it's not available. So, you identify somebody who is a user, and you're trying for that epiphany to get them to stop. What works? Well, here's what happens. If you take somebody who has an addiction or an opioid use disorder and just tell them to stop cold turkey, their chance of success is 2%. After 3 times attempting, their chance of success is 0.2%. They're done for life. They're addicts for life. They're going to abuse for life. If you put them in an opioid replacement therapy program, here's how it works, the measure of success. 1/3 stay on an opioid replacement medication, Methadone or buprenorphine, for the rest of their lives. 1/3. That's just like, oh, that's right, someone with diabetes stays on insulin for the rest of their lives. It's no different than that. And they lead successful lives, they go back to work, they're good with their families, life is good. That's 1/3. 1/3 have successful lives, go back to their work, do everything, and they get weaned off the opioid replacement medication over 2 years. That's 2/3. 1/3 crash and burn. Have you heard the term running the gauntlet? That's the methadone clinic. Because when you go to the methadone clinic for your dose, you run the gauntlet. Because outside the clinic are all the opioid sellers who know that you're going into that clinic to get your methadone. So they're out there saying, hey, you want some, man? Hey, you want some? Hey, you want some? So you go buy 5 or 6 of them on the way in to get your methadone. That's called running the gauntlet at a methadone clinic. So 66%, but that means 30% of people who develop an opioid use disorder, their lives fall apart. Which means we should be doing risk assessment because that's a lot of people whose lives fall apart. So, how can we help them in the ED? We know about 2 measures in particular, clean, safe needle programs. How many of them have in your community? Really? Not very many? How many just don't know? That's probably more true. And the free naloxone kits. How many have those? How many give them out in the emerge? Okay. There's an article there that talks about it, but what's really important to know, how many of you have carfentanil in your city as a drug of abuse? Must be from Canada, one of them, because in Toronto it's everywhere. All the paramedics now wear gloves up above their elbows because carfentanil is absorbed through the skin and can kill the paramedics. Naloxone doesn't reverse carfentanil because it's way too potent. it takes 3 micrograms of carfentanil to kill you. So when I have an opioid overdose show up in my emergency department, I intubate them. Because almost 30% of our overdoses in the hospital I work in Toronto involve carfentanil. It's a waste of time and it's putting the patient at risk to try and reverse them with naloxone. If they take fentanyl, because that's the most common mix with heroin in my city, it takes up to 10 milligrams of naloxone to reverse them. Carfentanil can't be reversed with the naloxone I have in my department. So it takes a long time to give 10 milligrams. It takes an even longer time to give an infinite dose of naloxone. So I just intubate my opioid overdoses if they're really down. The paramedics have already tried some naloxone. I'm not wasting my time giving more. But that depends on where you work to know if that's the approach you should take. But you should know how much carfentanil is in your community. You should be talking to police on a regular basis because it changes the game. Your paramedics have to act differently. You have to act differently because if there's white powder on a patient in my emergency department, you're fully dressed because carfentanil can kill the healthcare worker. So, what is buprenorphine and what is required to prescribe it? How many of you are giving buprenorphine in your emergency departments? 1, 2, I do. So, if you're a healthcare provider in the United States, as a physician, you need to take an 8-hour course. It's online. It's really easy to do. If you're an NP or PA, it's a 24-hour course because apparently for reasons beyond me, they think it takes 3 times longer to learn the same information. I don't know why they think like that, and maybe you can explain it. It makes no sense to me. But you have to take the course. You then get your DEA numbers changed and different letters added, and it says you're allowed to prescribe this. In Canada, we're much easier. Anytime I want to use buprenorphine or methadone in the emergency department, I can just prescribe it. I only need to take a course if I'm going to give it on an ongoing basis. But in the United States, if you want to do it in the emergency department, you have to have taken the course. It's not a barrier. It's to get you to understand. So, buprenorphine is almost always combined with naloxone for a very simple reason. In a pill, what is it? It's so they don't grind it up and inject it. Naloxone is just essentially not absorbed PO, but it does work to prevent constipation from opioids when taken PO. But if they grind up the pill and inject it, then naloxone prevents the buprenorphine from doing anything. But we have to recognize that buprenorphine is an antagonist-agonist effect, okay? So if you've been taking heroin and you're high and someone gives you buprenorphine, you go into withdrawal right in front of them. And it's not nice. It's like you just gave them a whack of naloxone. They get into trouble very quickly. They start shivering and puking and looking at you like you're the devil because you are. Okay? How much does it cost? A single dose is $10 each for 8 milligrams, and that's a rare dose. It's rare that people are on 8 milligrams. The starting dose, once you get them going, is 16 or 24. So we're talking about every time they take a dose, $20 to $30 a day. So it's not cheap. So the caveat about using buprenorphine you have to understand is if you have to see the patient and they're in severe pain while they're taking Suboxone, it's miserable trying to treat their pain when they're on Suboxone. Buprenorphine is highly competitive for mu receptors, much more so than Methadone. And if you think they need to get an opioid, the guy spills his Harley and has an open fracture of his femur and six broken ribs, and you think he needs opioids as part of his pain management, so you're going to use a locked PCA pump. You have to use fentanyl, because it's the only one that has a high enough mu receptor specificity. And even then, it probably doesn't work well with buprenorphine on board. So what is recommended is if they're on buprenorphine and you think they need opioids as part of their pain management, you have to switch them over to Methadone. Just remember, when you're thinking about, I don't know, do I really want to give this person Suboxone, what the hell? Just remember, 2% success rate if they try to do it on their own. 66% success rate with opioid replacement therapy. Okay? 2%, 66%. It is the way to treat people. And you say, yeah, but I'm just replacing an opioid with another opioid. Yeah, you're replacing their lack of insulin with insulin. Get over it. Okay? So, what about meth? Yes?
What's the timing on starting it?
I'm going to get into that. If someone comes into your emergency department and says, I'm really hurting, man. I got my methadone. I couldn't get my care in. I really need it. You relax, because they're lying. Methadone is given every 24 hours, right? But it has a half-life against withdrawal that's 36 hours. So when they come in at hour 25 and say, oh, they're faking. There's 36 hours, and they always exaggerate the dose that they need. Most people are on about 60 milligrams of methadone a day in their dosing. What you do is whatever dose they say they take, you give them a third of that dose. And you wait an hour to see if they get really drowsy. Because if they get drowsy, they were lying about their dose. If they're wide awake, you give them the same dose again. And you can do it again in hour 3. So you get to the total dose they said, but it's still within the 36-hour window. But you don't overdose them with methadone. Okay? So methadone, they have a 36-hour window, so when they're 1 hour past their 24-hour limit, they're not in withdrawal. And you give them 1/3 the dose every hour to make sure you don't overdose them with the methadone. Okay? So, what else do we need to know? Methadone, you have to earn trust. So it's different with buprenorphine. Methadone, you start and you have to take it in front of the treater every day until you earn trust. And then you get one carry. You take it and you get another one to go home and you can take it the next day. So you don't have to come to the clinic every day. And you can get to a point where you're up to 7 carries. You get enough for a week. And they test your urine from time to time and they see what's going on with you. Did you successfully run through the gauntlet? Did you not successfully? Oh, look at that. You tested negative for methadone. You tested positive for this. You're back to no carries. You have to come in every day to the clinic and you have to take the medication in front of us. That's how it works with methadone. Buprenorphine, you can prescribe the medication. Family physicians or nurse practitioners can take care of it in a clinic. They don't need to be seen every day because they can't misuse the drug. And if they take an opioid, unlike with methadone, if they take an opioid when they're on buprenorphine, it doesn't go well. So they have to stop the buprenorphine so they don't get into trouble. So, does it work? If you give people information about an opioid withdrawal clinic, and in Toronto we have lots of them, they're very well organized. Unlike in lots of parts of the United States where there's a paucity of opioid replacement clinics, in Toronto there's literally 8 within 3 kilometers of my hospital. I'm in the poorest socioeconomic area of Toronto. And so we can get them there easily. If you just give them pamphlets, and article number 7 talks about this, if you just give them pamphlets, 38% success at 30 days. If you give them the buprenorphine and get them the pamphlets and refer them, 78% success at 30 days. Big difference. So how do I dose it? The first thing you have to do is you have to use the COWS table, and it's in your chapter. They have to score at least 8, showing signs of withdrawal, and it's really easy to get to 8 because the maximum score is 40. It's really easy to get to 8 because they have to show some signs of withdrawal, otherwise the medication you give them puts them in withdrawal. Then you give them 4 milligrams of buprenorphine, of Suboxone, 4 milligrams. And you check their LFTs. And after an hour, if their LFTs are okay, you give them another 4 milligrams. So that's 8 milligrams that day. And you refer them to a clinic where they will probably give them 16 milligrams on the second day. But nobody recommends 16 milligrams the first day. So 4, then 4, checking their LFTs. All right. What can happen if I give it? I can precipitate withdrawal, obviously, because I didn't use my COWS score. It's really hard to use opioids like I talked about. So, to finish up, Rick added this thing to my chapter because there's something that came out in Annals of Internal Medicine. the last part there, where he talks about 7 recommendations. And I'm going to go through them because I don't agree completely with all of them, so I'm just going to read them. A medical setting is needed for induction. Well, yes, but it doesn't have to be the emergency department. It can be a clinic. It can be a family doctor's office. They say that home induction is also safe and effective, but I will tell you the caveat. Their LFTs have to be normal for them to do that. Benzodiazepine co-prescription with buprenorphine is toxic, with the author suggesting that they should not be withheld. I will tell you, in all my years working in clinics, benzos are the enemy of the devil. They are bad. You can get people off opioids by weaning them off over 10 weeks or so. You can't get people off benzos. I have tried, and you never get them off the last 10%. You just can't. 2, the combination of an opioid and a benzo almost always results in central sleep apnea. So they're getting hypoxic during the night. And they get hyperalgesic states the next day. So their pain becomes worse because of their central sleep apnea. So benzos with opioids, I disagree. I just can't encourage them or support them. Relapse indicates a patient is not fit for buprenorphine-based treatment. The authors say indicates the need for additional support and resources rather than cessation of treatment. And I wrote, agreed. However, data shows that failure with ORT 3 times offers a chance of success of less than 0.2%, so you have to take that in mind. And in Germany, you failed opioid replacement therapy 3 times, the state refuses to provide financial support for your care anymore. Because the chance of success is 0, and they said, you're going to crash and burn. It's not the health system that's going to pay for you. Number 4, counseling or participation in a 12-step program is mandatory. I don't believe that. But they say behavioral treatments and support should be provided as desired by the patient. I disagree with that. It has been shown that opioid replacement therapy by itself without multidisciplinary support is only 1/3 as successful as opioid replacement therapy with multidisciplinary support. You can't just give out pills. It doesn't work. Just like you can't just give pills for chronic pain. Drug testing is a tool to discharge patients. They disagree. It's to support recovery and address relapse. I write, it's best used first in assessing opioid risks and in monitoring deviancy from programs to adjust approach. I have seen 30-year-olds who have had positive or negative urines because they weren't taking the drugs because their moms were selling the drugs at age 65, 70 in their retirement homes. I've seen moms who are 65, 70 who tested negative in their urine because their sons and daughters were selling the drugs. It goes both ways. Urine drug testing is essential for you to best help the patient. Use of other substances is a sign of treatment failure. The authors say buprenorphine treatment does not directly affect other substance use, and as such, use should be addressed in this context. That is true. Marijuana testing in my country says it's now legal. If they test positive, they test positive. It's like saying they test positive for alcohol. But if you test positive for cocaine when you're in an opioid replacement therapy program, you are selling your substances to get cocaine. And that has to be confronted and dealt with immediately. And if they continue to test positive for cocaine, they do have to leave the program. But it has to be discussed and worked on first. Finally, buprenorphine is short-term treatment prescribed with tapered dosages for weeks to months. It's not. 33% of people who have success will be on Suboxone for the rest of their lives. And that's perfectly okay. All right, questions? If you take carfentanil, no matter what you're taking, you're in trouble, period. Its specificity for your immune receptors is incredibly high. You only need to have 5 to 10% of your immune receptors occupied with carfentanil to die.
So the carfentanil chemistry is going to overcome the naloxone?
Yep. Yep. No, the naloxone essentially doesn't exist when you're taking carfentanil. Carfentanil is a bad drug. It's a opioid that's 1,000 times stronger than fentanyl and is used for large... Well, I don't know if it's going through the Mexican border. I'm in Canada. It comes through Vancouver and Montreal. But it's actually an available medication. It's a approved medication for large animal anesthesia, for elephants, hippopotami, stuff like that.